Hello, welcome to this Expert Perspectives post-conference highlights on MASLD and MASH from AASLD. Next slide. I'm Nancy Rowe from Rush University Medical Center, and I'm joined by two of my esteemed colleagues, Joseph Ahn from Endeavor Health in Chicago, Illinois, newly moved there, and Ann Moore, nurse practitioner from Arizona Liver Health in Phoenix, Arizona. Next slide. We want to thank Novo Nordisk for supporting the CME activity with an unrestricted educational grant. Next slide. So a little bit of program overview. This is an educational initiative that was jointly provided by the University of Cincinnati College of Medicine, CLDF, GHAPP, and it focuses on expert perspectives of MASLD and MASH. There are a few key points. The series is accredited. It will feature live stream meetings. It's going to review and discuss some of the new data on the metabolic dysfunction-associated steatotic liver disease, now called MASLD, as well as its more aggressive subtype MASH, or metabolic dysfunction-associated steatohepatitis. This series does include archived live streams and additional educational resources available on the CLD and GAP educational portals and GAP's mobile apps. We really want to encourage you to go to those places. And the target audience is really all clinicians managing these types of individuals. Next slide. There are some disclosures and want to assure that the learner that we have full accreditation, that we promise to, outline off-label disclosures, and that there is a disclaimer that these are our opinions and you should not blame the University of Cincinnati. Next slide. As promised, these are our disclosures here, both of the planning committee as well as the faculty. Next slide. And then accreditation, if you go through the entire program, will give you one AMA PRA Category 1 credit. Next slide. When I outline the educational objectives, upon completion of this activity, a participant should be able to discuss emerging data on diagnosis and monitoring of MASH, analyze current and potential pharmacologic management strategies for MASH, which now include GLP-1 agonists, integrate weight loss into MASLD and MASH disease management strategies. Next slide. You want to claim your credits. In order to do that, you want to have done a pre-test, but that's not wasn't mandatory. You want to do the post-test, you want to do the program evaluation, and you want to do credit selection. And you can scan the QR code that you can see in order to get started on this. Next slide. All right, I'm going to give just a little bit of background. MASLD and MASH is a current and growing crisis in the US and worldwide. You can see from this map, which was recently updated, that there's huge prevalence in places like Latin America, the Middle East, North America. Almost a third of our inhabitants actually have metabolic dysfunction-associated liver disease. Next slide. There are some populations that are really at risk. So although around 31% of North Americans have MASLD, next click, almost 70% of North Americans with type 2 diabetes have MASLD. So really, when you're talking about focused screening, you really want to hone in on those individuals with prediabetes and diabetes. Next slide. And then of these individuals, only a small subset will have risk for significant progression or MASH. However, when you're looking at this sizable amount of individuals, that around 5% is really a lot of the patients that we're managing. Next slide. So we're all aware of the care continuum. You go from a healthy liver to steatotic or simple steatosis, and then depending on how many risk factors, whether it's genetic or concomitant liver diseases or concomitant metabolic abnormalities, or just your risk of fibrosis, people will progress. The chance of going from simple steatosis to cirrhosis is actually quite low. But once you cross the threshold to metabolic associated steatotic hepatitis or MASH, then that increases. And there are some rapid accelerators, but for the most part, going from F0 to F1 is a large step, but going from F2 to F3 to F4 are smaller intervals. And remember that although a minority of our patients are going to progress to decompensated liver disease, about 20% of the total population does have risk for progression. And so staging once is not appropriate. You have to make sure that you retain these individuals in longitudinal care and make sure that they realize why their liver health is important to them. Next slide. So, high risk individuals are sometimes hard to recognize, but some of the more common factors that you want to be aware of are increased BMI. If your BMI is 30 or greater, up to 90% can have MASLD, depending on other risk factors and ethnicity. Type 2 diabetics, remember I already outlined that almost 70% are going to have concomitant MASLD. Patients with cardiovascular disease have a high risk of metabolic associated steatotic liver disease, up to 70%. And hypertension, about half of our patients with hypertensive disease will also have MASLD. And remember that hypertension is one of those risk factors that increases progression of your MASLD also. So that it has been one of the concomitant metabolic abnormalities that seems to increase the risk of progression of liver-related injury. Because of all of these things, MASLD is really seen as the liver manifestation of metabolic syndrome. But not every MASLD patients have metabolic syndrome. So you want to make sure that you have a broad swath of worrying about the patients in front of you. But if they clearly have multiple metabolic abnormalities, it's very common for them to also have fatty liver disease or MASLD. Next slide. When you're in the liver world, our emphasis is really on fibrosis. Now, this could change as our diagnostics and our therapeutics change, but right now we know that increasing fibrosis or increasing liver scarring increases the risk of liver-related mortality as well as all-cause mortality. And that's why we think that staging and repeated staging is really important for our patients as they start to have an increased risk for other injuries as well as liver-related risk. Next slide. All right, our approach for currently available treatments, and remember we do have options, although not a lot of them are pharmacologic, are three-pronged. You want to control obesity and those metabolic abnormalities. So remember that with weight loss, we do have lifestyle as well as weight loss medications that are not just GLP-1s, and these are very appropriate alternatives for patients that are good fits for some of the other options. Bariatric surgery, whether that's endobariatrics or more surgical bariatrics, these are really good strategies for some of our patients, especially in my clinic, on my younger patients that we're going to be battling these metabolic abnormalities for a long time. And then remember that our GLP-1 receptor agonists are approved for weight management, may not be always accessible from an insurance standpoint, although that's changing, but we really want to focus on weight loss. And remembering that, as we will point out in some of these abstracts, that lifestyle modifications are going to benefit the patient holistically, not just lead to weight loss. You want to address those metabolic abnormalities, so treat type 2 diabetes and cardiovascular risk factors. Here, hyperglycemia are ACE 2022 guidelines, which are the endocrinology AASLD guidelines, focus on using GLP-1s and SGLT2Is for patients who are at risk for MASLD who also have diabetes. Hypertension with ACE and ARB inhibitors, and then this dyslipidemia. Do not be afraid of your statins. These patients have cardiovascular risk, and so you do not want to miss an opportunity to make them healthier. And then you want to target NASH or MASH. Here we do have some liver-directed treatments. Traditionally, from the Pivens trial, we had vitamin E, but not there is some hesitancy around diabetes, and then pioglitazone, which is also a diabetic PPAR that's approved, but these have really been supplanted now by resmetirom, which is newly approved for at-risk patients with metabolic associated steatotic liver disease. Next slide. So we're going to really discuss some of the exciting emerging data on diagnosis and monitoring through from our recent AASLD. And next slide, I'm going to turn it over to my colleague, Dr. Joseph Ahn, to present the first abstract. Thank you.
Thank you very much, Dr. Rowe. I think that this is an exciting time. The liver meeting was notable for a plethora of abstracts in the MASLD space, and it's more than 500 abstracts, which is more than 20% of all the abstracts. So one can imagine the challenges of picking 7 abstracts out of 500, but we have done so, and we're going to highlight not just some of the cutting edge genomics kind of data that we're not going to get to talk about today, or the pediatric data that's out there, but I think some overlooked aspects of experience of things that impact the progression of MASLD. And I'll have 2 abstracts that I'll be talking about today, including touching on the cardiometabolic risk factors that Dr. Rowe mentioned earlier, that what is the impact of diabetes and alcohol use and obesity on the progression. And then we'll have some of these current completed real-world therapeutic drug trial results, as well as some of the latest medications that are out there. So let's see if we can progress. So this first slide, this first abstract is notable for a very large study coming out of the U.S. Veterans Association. So we normally have studies that are in the hundreds and thousands, but this study is notable for its strengths of having hundreds of thousands of patients in their study. And what they looked at was the impact of cardiometabolic risk factors among patients who are noted to have steatosis or fat in the liver. So this was using the National Veterans Affairs data, patients with MASLD or metabolic liver disease and alcohol use disorder from between 2010 to 2018. And what they were looking for is the impact of multiple cardiometabolic risk factors, specifically the impact of obesity, as well as the impact of diabetes on progression of patients with MASLD, as well as metabolic liver disease and low alcohol use. Now, it seems to stand to reason, and we all know as clinicians, having diabetes and obesity is a risk factor for progression. But surprisingly, we don't really have great large-scale data that supports this. And this study evaluated what happens if you take into account diabetes and obesity in these 2 patient populations. So they identified the MASLD group as not having significant alcohol use, and the MET ALD group, which is metabolic liver disease plus alcohol liver disease, is having low levels of alcohol use. They excluded all other causes of liver disease, and then they looked at, over time, what is the progression or the incidence of cirrhosis in this patient population. And here's what they found. On your left here is MASLD, and on your right is metabolic liver disease with alcohol liver disease concomitantly. In the blue are those patients who do not have diabetes or obesity. In the yellow are those who have diabetes or obesity, and in the purple are those who have both. Note that there's more than 680,000 patients included in the MASLD and more than 500,000 patients in the MET ALD group. And they looked over time, x-axis is time, and the y-axis is the cumulative incidence of cirrhosis. And you can see very clearly that even after a couple of years, the curves start to diverge. And having diabetes or obesity is not good, but having both is worse. Now, this is self-evident, but now we have a very large population-based study that shows that the risk goes up by more than 21 to about 30% if you have diabetes and obesity in patients with metabolic liver disease or MASLD and those with MET ALD. So having one is bad, having 2 is worse. Let me then turn this over to my esteemed colleague, Ms. Ann Moore.
Hi, everybody. Boy, the liver disease world has had a ton of activity in the last year, and I think the liver meeting was really energized this year, and I'm not quite sure how we picked 7 abstracts either, but we managed to do it, right? And certainly there was a lot going on with MASH and MASLD this year. So let me see if I can operate the slides here, maybe. All right, so this next abstract reviews the impact of exercise on MASH resolution. And we talk to our MASH patients about the importance of exercise at nearly every visit, right? But we tend to focus more on weight loss. So it's really nice to have a study from Dr. Channa Pragrata and colleagues that shows that aerobic exercise training without weight loss can lead to MASH resolution. And it was defined by the MASH Resolution Index. The MASH Resolution Index is a validated composite score of multiple serum and imaging-based biomarkers, which was used to evaluate whether exercise training improves liver histology independent of weight loss. And this is a post hoc analysis of an exercise trial where individuals with MASH did not lose significant body weight. The NASHFIT trial was conducted between May 2018 to February 2021 and enrolled 28 adults, a low N, but still, and the age was between 18 and 69 with biopsy-proven MASH. So for some reason, my slides aren't advancing. There we go. So in those who received exercise training, nearly 3 times more achieved MASH resolution than those in the clinic, in the standard clinical care, 33% as opposed to 13%. And also there was a 4.3% reduction in absolute MRI-PDFF in the exercise group compared to a 1.2% gain with standard clinical care. And finally, there was a 24% reduction in ALT in the exercise training group as opposed to the standard clinical care group who had a 10% reduction. Now, the mean BMI in this population was of study patients was 33.8. So in Arizona, that's thin, actually. 56% were F0, F1 patients, 22% F2, 17% F3, 4% F4, and there was no weight loss over 5% in either group. Also, each individual parameter contained in the MASH Resolution Index changed more significantly with exercise intervention. So that's pretty interesting. I think the case for exercise is strong here. So the conclusions here are that exercise training leads to MASH resolution independent of body weight loss in adults with MASH at greater rates than standard in-office lifestyle counseling. So, you know, I think the combination is better, but we can't leave out exercise when we talk to our patients. And this study also provides some new evidence about the MASH Resolution Index. We're more into non-invasive monitoring tools. We are not going to biopsy all these patients. So this is a potential tool that could be scalable at the population level to discern therapeutic response to lifestyle interventions that we recommend to all of our patients. So I think it's kind of exciting, even though the N is small, it showed some very positive results. And so now we're going to move back to Dr. An to cover the next abstract.
Thank you. I was hoping to hear that I didn't have to exercise or tell others to exercise, but unfortunately,
Me too,
that has
actually.
been proven wrong by the data. So this is the number 2 in terms of risk factors that affect patients with MASLD. And this was a multi-center prospective study looking at patients who have MASLD and those who have diabetes. And the question here was that there was limited data on the rate of progression of patients with liver stiffness measurements. And let me see if I can get this to advance. There we go. So it's, again, these type of studies, when you look at it, it seems obvious. But I think they're the best type of studies because we assume things, but we have to have data to help back up what we tell our patients. So, for instance, we just talked about in the first abstract that the presence of diabetes and obesity is a risk factor for progression to cirrhosis. I think we knew that clinically, but now we have data saying those are two clear risk factors that significantly increase patients who have steatosis or fat in the liver and their risk of progression to cirrhosis. This study looked at whether or not having diabetes was associated with the risk of progression in the MASLD. And in this case, specifically, whether we can use the liver stiffness measurements by vibration controlled transient elastography, or VCTE, because we can't always just repeat liver biopsies. I'm going to show you a study later where they had 3 liver biopsies in 96 weeks. But in real life, we really can't get people to repeat liver biopsies very often. So we need surrogate or non-invasive testing to see whether people are progressing. So this prospective study looked at adult patients with biopsy-proven MASLD who had VCTA or elastography at least 1 year apart. There was over 8 sites. And they looked at whether or not there was progression or regression of the liver stiffness measurements based on one, at least a 20% change, and whether or not they went up or down in the Baveno 7 liver stiffness measurements categories. And for those of you, just to have background, these are recently recommended and accepted in the Baveno 7, which is a large portal hypertension consortium of experts, and this was also incorporated in the AASLD MASLD guidance. And they looked at the difference between having diabetes or not having diabetes at baseline. So there was more than 1,200 patients over 8 sites, and they all had MASLD, biopsy proven, and nearly 700 had diabetes, and about 550 did not have diabetes. They were mainly female, age was about 52, BMI, you know, was a little bit above average, even for Arizona, and that the mean time between VCTE was about 4 years. So that's the background. And if we look at the graph, here's what you see. X-axis is time in years, and the Y-axis is the progression of liver stiffness measurement. And note orange are those patients with diabetes, and the purple, in this case, are those who do not have diabetes. And what this showed is using serial VCTE data from multiple centers of biopsy-proven MASLD and prospectively following them, what it shows is that participants with type 2 diabetes have a significantly faster time to liver stiffness progression. And I think this is, again, seems obvious, but it gives us the data to say diabetes is not good. Voila, that's like an obvious thing. And that there may be impact if we can treat the diabetes as we are aggressively with latest drugs, including the GLP-1s and GIP-1s. So that is, I think, one connection that we have. And that this also helps us to know, I think, in some way that we can use non-invasive testing to monitor people. So let me turn this back over to my dear colleague, Ms. Ann Moore.
All right, I am back. And I believe I have a run of abstracts here, if I can change the slide. Not allowing me to. Okay. It's always with the, there we go, perfect. So I have a run of abstracts here, but we're going to start it off with resmetirom, a little bit of information about dosing in resmetirom. You may have heard of that drug, I don't know. So this abstract is from Dr. Norden and colleagues, and it assessed the efficacy of resmetirom 80 milligrams versus 100 milligrams, stratified by both the baseline body mass index and weight in patients from the Maestro-NASH registry trial. So let's see what happened with these patients, all right? We probably know this too, but I think it's interesting because the way the trial was randomized, as you know, Maestro-NASH is the registration trial, and it's an ongoing 54-month randomized double-blind placebo-controlled phase 3 trial looking at the efficacy of resmetirom in patients with biopsy-confirmed NASH and fibrosis. Resmetirom was FDA approved in March of 2024. The trial is ongoing, so they received accelerated approval. And although the trial was randomized 1 to 1 to 1, with resmetirom 80, resmetirom 100 versus placebo administered once daily, the label is weight-based dosing. So this will give you a little more information about why that is, I think. Histological endpoints were assessed after 52 weeks, and the dual primary endpoints for most NASH trials are the same. And in this trial at week 52, dual endpoints were achieved in both the resmetirom 80 and 100 milligrams arms with NASH resolution with no worsening of fibrosis, or a 1 or greater stage in rejection in fibrosis with no worsening of the NAS score. Okay, so we also know that body weight is a major influencing factor influencing exposure to resmetirom in these patients. And this post-hoc analysis was performed to provide additional evidence of a relationship between the resmetirom dose, the baseline weight, and the BMI. So let's look at the results. Okay, so first we'll take a look at baseline weight and efficacy. So for patients with 80 milligrams who were treated with 80 milligrams of resmetirom, who weighed 100 kilograms or less, the 30% PDFF response was 66.9%. And in patients with a 52-week biopsy, 35.4% of them showed fibrosis improvement, compared with 32% who showed no worsening of fibrosis. In the 80 milligram arm in patients who weighed over 100 kilograms, the 30% PDFF response was 56.7%, with fibrosis improvement in 22.5% and NASH resolution in 27%. Now let's look at the 100 milligram arm of resmetirom. And those patients who weighed 100 kilograms or less, the 30% PDFF response was 71.7%. And fibrosis improvement was noted in 33.6% and NASH resolution in 35.8%. For patients over 100 kilograms, the PDFF response was 72.5%, fibrosis was noted in 32.5%, and NASH resolution in 35.8%. So patients who weighed over 100 kilograms definitely experienced lower efficacy with that 80 milligram of resmetirom arm. Okay. Oops. Oh my goodness. So now we're going to look at baseline BMI. I don't know if my slides are my computer's being wild here. Sorry, I apologize. We'll look at efficacy stratified by baseline BMI. And the increases in fibrosis improvement were noted relative to placebo for patients who received 80 milligrams of resmetirom, who had a BMI of less than 35 of 13% and NASH resolution of 33.4%. And in patients with a BMI of 35 or greater, fibrosis improvement of 7% was noted, with NASH resolution 9.8%. And then increases were also noted relative to placebo for patients who received 100 milligrams of resmetirom, who had a BMI of less than 35, and fibrosis improvement of 11.8%, NASH resolution at 21%. And for patients with a BMI of over 35 or greater, fibrosis improvement was noted in 11.1% and NASH resolution in 20%. So we note the patients with the BMI greater than 35 experienced lower efficacy with the 80 milligrams of resmetirom again. So conclusion of this abstract was that resmetirom 100 was consistently more effective than the 80 milligram dose in achievement of the dual primary endpoints in the sample of patients who had a higher baseline body weight and BMI. In patients with a lower BMI, there was no observed difference in the efficacy between the 80 and 100 milligram doses. And that is why we have the label, one of the reasons we have the label that we do, that is weight-based dosing. Okay, so I think I'm just going to continue on here. And we are going to talk now, we're going to switch to the GLP-1, which is really, it's all the buzz these days, right? So this abstract looks at GLP-1 receptor agonists in patients with MASLD. It's from Alfred Barrett and colleagues, and it looks at MASLD patients who are on GLP-1s in a real-world setting, and the association was slower disease progression and lower all-cause mortality. So GLP-1s for the treatment of diabetes and obesity have been widely studied. There's increasing interest in patients with MASH and MASLD, although we have limited data in real world. So this analysis describes characteristics and disease progression across the spectrum of MASLD patients as part of usual care after they're prescribed GLP-1s. So the population for this study was the target NASH US cohort, which includes a lot of patients, which we'll talk about in the next slides, but it included adults enrolled between 2016 and 2023, with 6 months of follow-up without a liver transplant or HCC. They had to be on GLP-1s for at least a year, and then they looked at baseline characteristics and competing risk-adjusted model results for progression from compensated to decompensated MASH cirrhosis and all-cause mortality. So there's 6,603 target NASH US participants, and 4,219 met the analysis criteria, 1,311 in the MASLD group, and 1,331 in MASH, and 1,577 in MASH cirrhosis. The data set included 375 patients on GLP-1s, 86 MASLD patients, 74 MASH patients, and a lot of patients with cirrhosis, 215. And these patients had been on GLP-1s for quite some time, 2.5, 3.2, and 3.3 years respectively. The GLP-1 users versus the non-users more commonly, as you would expect, had type 2 diabetes. They enrolled at an endocrinology site, and they had higher BMIs. And this is interesting also. Overall, 20 of the GLP-1 users died, and 33% or 20% progressed from compensated to decompensated cirrhosis versus 243 and 217 non-users, with a median time to decompensation of 24.2 versus 21.2 months, respectively. So this is a kind of a busy slide, but we'll give it a go here. So the adjusted hazard ratios resulted in higher risk for all-cause mortality and progression from compensated to decompensated cirrhosis for the GLP-1 non-users compared to users with a hazard ratio of 2.28 and 1.69 respectively. Those patients with type 2 diabetes, hypertension, and those over 60 years old had a greater risk of all-cause mortality versus those without risk factors, and those with hypertension were at greater risk of progression to decompensation. So conclusions here were that there were significant differences in baseline characteristics and all-cause mortality in the GLP-1 users versus non-users across the spectrum in this real-world setting of the target NASH population. And most importantly, compared to the GLP-1 users, non-users had more than twice the risk of all-cause mortality and 1.7 times the risk of progressing from compensated to decompensated MASH cirrhosis. So if you weren't interested in GLP-1s for MASH, you might be interested in now, right? So while most patients were likely treated with GLP-1s for their type 2 diabetes, the recent approval of GLP-1s for obesity, when you can get them approved by insurance, definitely warrants further investigation into long-term safety and effectiveness of these medications for patients with MASLD. And I think the next study that I'm going to talk about discusses just that. So this is a look at semaglutide in metabolic dysfunction-associated steatohepatitis by Philip Newsom and colleagues. And this was data we were all waiting for, at least I know I was, right? So our site participates in the ESSENCE study, and we really were kind of on pins and needles wanting to know if GLP-1s could make a dent in fibrosis. We know they do in steatosis, but let's see what this interim analysis looked like. So semaglutide, as you know, is a GLP-1. It's being looked at as a treatment for MASH, and the trial is in phase 3. It's the ESSENCE trial. It's an ongoing multi-center phase 3 randomized double-blind placebo-controlled outcome trial. And there's 1,200 enrolled participants with biopsy-defined MASH with fibrosis stages of F2 and F3. They were randomized 2-to-1 to receive either once weekly sub-Q semaglutide at 2.4 milligrams or placebo for 240 weeks. So this is a long trial for patients to participate in. There was a planned interim analysis at week 72 of the first 800 participants, which evaluated the trial's primary endpoints, which are the same for most NASH trials: the resolution of steatohepatitis with no worsening of fibrosis, and improvement in liver fibrosis with no worsening of steatohepatitis. So let's take a look at what happened. So NASH resolution was achieved in 62.9% in the semaglutide group versus 34.1% in placebo, a difference of 28.9%. Fibrosis improvement, which I was particularly interested in, occurred in 37% of the semaglutide group versus 22.5% in the placebo arm, which was a 14.4% difference. And 32.8% of the semaglutide arm and 16.2% of the placebo arm achieved combination resolution of MASH and improvement in liver fibrosis. And this was a 16.6 difference between the groups. Patient characteristics in this trial, as you can see, mean age was 56. Most patients, 67.5%, were white, 57.1% female, 55.9% type 2 diabetes. But look at this patient population. 68.8% of these patients had advanced fibrosis at F3. So I think these are pretty promising results for this interim analysis. And so other endpoints were met as well: improvements in liver enzymes and non-invasive fibrosis markers, improvements in body weight, as you would expect, and cardiometabolic parameters as well. And also the incidence of serious adverse events in the safety analysis set was similar in both the treatment and placebo arms. So conclusion is, in participants with MASH and moderate to advanced liver fibrosis, semaglutide 2.4 milligrams once weekly demonstrated superiority versus placebo for improvement of histological activity and fibrosis markers, meeting both primary endpoints after 72 weeks of treatment. In addition, semaglutide improved MASH injury and fibrosis biomarkers and cardiometabolic features. And this gives us hope for an exciting 2025 potentially, and maybe a new treatment option for MASH. So stay tuned for that, right? So I'm pretty excited about that finding. And again, I'm going to be stuck on my slide here. I cannot advance. Okay, there we go. So I'm going to turn it on over to Dr. An now.
Wow, that was a whirlwind tour. Thank you, Anne, for giving us that tour through those three important abstracts. I'll be talking about this very exciting new update on a drug called efruxifermin, efruxifermin. You know, I will call it EFX since I've always had some trouble pronouncing it. But this drug is a fusion protein of a human IgG domain and a modified human FGF21. And what FGF21 is, a fibroblast growth factor. It mimics the naturally occurring FGF21's agonism, and it selects and binds to these receptors. And downstream of this, what happens is that it alleviates cellular stress and regulates metabolism throughout the body. And EFX seems to reduce liver fat and inflammation, reverse fibrosis, increase insulin sensitivity, and improve liver metabolism. So this is a very exciting development that is in the space of MASL. And there was already some report of this study called the Harmony study, and there were reports of 24 weeks. And what this was, a follow-up 96-week update on this Harmony study. So it was on patients who had biopsy-proven MASH with stage 2 or 3 fibrosis. And previously that they had looked at the results and 3 groups: placebo, lower dose, higher dose. And patients were followed to see whether or not there was improvement in fibrosis with no worsening of MASH, as well as some of the other factors, such as the NAFLD activity score improvement. And what they found after assigning to 3 groups of the placebo 28 milligrams weekly sub-Q or 50 milligrams sub-Q is at 96 weeks, we have follow-up data with biopsy at baseline, 24 weeks and 96 weeks. And this study is notable for having a standard histopathology as well as digital histopathology with fancy pants artificial intelligence assessment, and they compared that. So prior, we had known that at 24 weeks, there was a significant improvement in patients who got the drug EFX versus placebo. And people had fibrosis improvement. There was improvement in the NIS. And this study, follow-up in this abstract in figure 1, are patients who have had near complete reversal of disease. That is, they had fibrosis improved to less than 1, and MASH resolution, and normalization of hepatic fat to less than 5%. And this is the trifecta. You get rid of the fibrosis, you get rid of the inflammation, and you get rid of the fat. Now, the only thing to temper our enthusiasm is that these numbers are not thousands or hundreds of thousands like I had for the first abstract. But this is a very exciting development, because even though there's about 30 patients in each arm, you had more than up to 30% of patients who hit normalization of fibrosis, MASH resolution, and hepatic fat content being essentially gone after 2 years of therapy. And now I'm not going to have time to talk about the safety, but the EFX was generally well tolerated across multiple clinical trials. And the main events, side effects were diarrhea, nausea, vomiting, very similar to some of the GLP-1s that are out there in some injection site. But this next figure B is showing the reversal of at-risk MASH. So placebos here, the lower doses here, and the higher doses here. And in the purple are no longer meeting any of the criteria for at-risk MASH. And the gray is no longer at-risk MASH, but not like the trifecta of everything being gone. And the orange or yellow are those patients still at risk. And I think these colors can show you, and just by itself looking at it, is that there's a significant reduction in the risk of MASH and risk of MASH progression. So we don't have time to show some of the other data, but the 50 milligram was associated with a significant reduction, both in the regular pathology as well as digital pathology. And just as an aside, this is a new development of using digital histopathology that might allow us to not rely on humans, but have this being checked by AI as well. But in conclusion, what we have is unprecedented antifibrotic activity observed after 96 weeks. And in subjects with F2 to F3 fibrosis, a significant component of near complete disease reversal, with only a few subjects remaining classified as being at risk. And this is only after 2 years. Now, what do we need to do is we need to take a pause, recognize that this is a small number of patients. We need larger data sets. But I think this is a new development that tells us the MASL space is very exciting. With all the cool things that we've heard from Anne about the GLP-1s, it gives us another option of a multi-pronged approach as we think about the management and treatment of MASL. So a lot of exciting things to come. Let me turn this back over to Dr. Rowe.
Wonderful. So thank you so much for filling in the gaps that we might have missed from AASLD. And we do have a number of audience questions. The first one, submitted by Christine, is around the interval of liver stiffness measurement, or VCTE. And she specifically wanted to know when you redo them and if there's a difference between if the liver enzymes are normal or abnormal. And Joseph, maybe I'll give that to you.
Yeah, and I think this is a very practical question. And unfortunately for our being busy and being able to maintain our practice, these patients with MASL, they're going to be showing up at our doorsteps. And I would just direct Christine to the AASLD's 2023 guidance the MASLD guidance, which has a really nice figure. And what that figure number 2, I believe, shows us that you start with somebody who is incidentally noted to have some steatosis on imaging or mildly abnormal liver enzymes. And in the primary care world, we ask patients, the PCPs, to do a FIB-4, and that is a very cheap and non-invasive way. And if the FIB-4 is above a certain number, typically it's above 2.67, that suggests a possibility of more fibrosis. They are then referred outside of the PCP to the GI hepatology world, where a non-invasive testing is obtained, either through vibration-controlled transient elastography or ultrasound elastography, or ELF in those places that do not have access to that. We then use that VCTE. If it's less than 8, we say, hey, that's a low-risk patient. Send them back to work on their diabetes, hypertension, their cardiometabolic risk factors. But if it's intermediate, which is like 8 to 12 or high, we then progress on to further risk stratification, looking for other causes of chronic liver disease. Perhaps if there's a discordance in the clinical picture, this is where I might use MRE. But let's just say, to go back to your question, I would refer you to the AASLD guidance. So in this patient with normal LFTs and just some steatosis, who has a VCTE that's normal, I think that person can be referred back to primary care to work on the cardiometabolic risk factors, and you can follow that patient through a FIB-4. If you have somebody who has an abnormal VCTE above 8 and above 12, that person is someone that you should consider working up further for other diseases. If you assess them and they're closer to stage 2 or 3, that person is someone that you should consider for liver-directed therapy with resmetirom if you've excluded other causes. And that is a whole separate update in 2024 that has recommendations to repeat the VCTE, abnormal liver enzymes, stage 2 or 3 fibrosis on non-invasive testing or otherwise. You put them on resmetirom, you would repeat the VCTE in 1 year. If you don't put them on treatment and you're just monitoring them, you tell them to exercise following Ann's recommendations, you treat their diabetes and GLP-1, I think typically that's the kind of person that it would be reasonable to do a 1-year follow-up. And you can adjust that based on other risk factors.
Thank you very much, Dr. An. So I want to turn to you, Anne. You gave a really nice introduction reminding us that physical therapy, that physical exercise is really important. And you compare that in that study against standard of care. I know I tell all of my patients to exercise. So what do you do differently? Are you referring them to PT? Is there an app that you can use? Like how do you go above and beyond standard of care where we probably are talking about exercise to getting that person to actually do the aerobic exercise?
So I feel like this is a loaded question. I mean, the recommendation is 150 minutes of aerobic activity per week, right? And some of my patients think aerobic activity is pushing the button on the channel changer, right? So you really have to meet the patient where they are. You can't just tell a patient exercise and expect them to do anything. So it really varies from patient to patient. If I have somebody who's very sedentary, I may have them stand up and march in place during commercials. Like, I'm serious. Like any activity, there's been many studies, well, not many, but multiple studies have shown that any activity is better than no activity. So I think even if you're getting them to do 5 to 10 minutes of just moving their bodies to start for a lot of our patients and then graduate from there. I have a hard time getting physical therapy approved for my patients. I think it's an excellent option for somebody who's very sedentary and needs a starting point so they don't hurt themselves or go too far too fast and have an injury that will set them back. So physical therapy is a nice option if you can get it approved, but it's just meeting the patient where they are, finding out what they like to do. Maybe, if they're a group person, getting them involved with exercise classes at a gym or a senior center. I mean, there's many, many options, but the important thing is to really develop that relationship with your patient where you can have an honest conversation about how it's going to benefit them if they start moving more. So any movement is a win in my book.
Perfect. And I think that this messaging around exercise without weight loss still has benefit is also going to be important because I think my patients go to the gym once and they they aren't magically a supermodel and wonder, why they're going to the gym. So trying to emphasize that. Um, Joe, I'm going to turn to you now because there have been a number of questions about diabetes. Part one of the questions was if metformin still has a role, and I would expand that to how do you take someone who's been on more traditional agents, like whether it's something like a metformin or glipizide, and try to move them, or should they be moved to diabetic therapy that seems to be a little more liver favorable. How do you traverse that when you may not be the diabetologist, given all this new data now?
Yeah. So metformin is an insulin sensitizer. It's always been, before all of the advent of these drugs, we had some interest in as a benefit for MASL. But overall, there's been conflicting results and no specific drug recommendation to use metformin for MASL. It has been shown in animal models to reduce lipogenesis and some fat. And some studies show that improves insulin resistance and weight loss and glucose control. However, a meta-analysis of the RCTs showed clearly that metformin did not improve liver histology or biochemical outcomes or BMI. So it is not data-based to recommend metformin. So I think that is antiquated, but is it okay to use for diabetes? I think so. I think we have to defer to specialists who are better than at least I am as a hepatologist in managing diabetes. Now, the second question is, all right, we have all of these new drugs. We have exciting data with GLP-1s, GIP-1s. It's going to be like the Wild West of back in the day when Hep C drugs just became available. And it kind of made me think about where we are now with these medications is this. We are having more and more data showing they work. They work for pretty much everything short of alopecia. You can't grow hair back with it, but it seems to fix everything else, including people who want to drink too much alcohol, people who have depression. But we're having issues practically with insurance coverage, just like when we had the new drugs directly acting antivirals for hepatitis C. The other aspect that's historical is we're very busy. People have very busy practices. And can we take on, as GI hepatologists and non-diabetologists, of managing GLP-1s, their side effects? And even before the side effects, do you have the infrastructure to do the prior auths? Do you have the infrastructure to follow up on their management, following their symptoms, following and managing their GI symptoms? This is very similar to all of the data that we have for alcohol use disorder. We know that drugs work, but very few practices have taken that on because it is very practically difficult to do that. So I think in larger centers, like at OHSU where I was before, we have MASL champions. We have a multidisciplinary MASL clinic where we have a dietitian, we have bariatrics, we have endocrinologists, cardiologists, hepatologists. It's a multidisciplinary approach. And we had the luxury of people who are very experienced with GLP-1s. I didn't have to do anything with them. I just said, go and see these specialists and they will help manage you. In my new role at Endeavor, we thankfully have a weight management clinic and partners who are managing that. But I haven't felt the following: an impetus to take this on, practically because it's very new as a hepatologist. Two, I think there's practical barriers. But in the future, I do think that this may be coming our way as we have drugs like resmetirom, which is on us. We have other new drugs that will be coming on. And whether we like it or not, it may be coming to us. But I do think this will be part of a multidisciplinary process where we have to have the patient centered in the middle, and we're going to have to learn how to use these medications. I'm just hoping to wait a little bit because I have enough on my plate. And that's a very practical answer and what I hear from people that are in practice. But I'm curious as to what you do, Anne, in your large Arizona Liver Center.
Yes, so we are a private practice without the multidisciplinary advantages that happen in an academic center. So we have learned to use these medications and we are prescribing. The biggest hurdles for us now are typically insurance authorization. Obviously, at this point in time, many patients come to us already on the GLP-1s. And if they have an endocrinologist or a PCP who's interested in managing, certainly we collaborate with them and appreciate it when they order the GLP-1 and not us. But if there's nobody out there who's and we think it's the right thing for the patient, we are ordering, and then going through the laborious process of getting prior approval. And then really, if you don't follow these patients closely, they will drop off of care related to side effects. So you kind of have to stay on top of them too. So it's a big job. Takes a lot of manpower to manage patients on GLP-1s, especially when you're just getting started.
Yeah, and I do want to just follow up, Dr. Rowe, about your question about managing this, because I think one thing that we can do is, just like we educate people on the use of statins, like in one of your earlier slides, that the risk of hepatotoxicity is not increased in MASLD. As we gather more data and we are receiving this information, one of the things that I'm doing is educating, disseminating, and recommending that there is no contraindication to considering these newer agents for a multi-pronged benefit, not just for the liver, but for these other aspects. And I do say, hey, this is something that we have no problems with you using, but we have to have these people followed. And the other aspect is the rebound effect that we have to keep in mind, and the management of side effects, as you said. So I think we're in a time of transition, and I bet as we have even new drugs coming out over the next year or two, people will become facile, will get more comfortable, and I think more people will have to do that because we don't have enough providers to treat the obesity epidemic otherwise.
Thank you both. I want to at least address one question on the use of resmetirom. It really is focused on the dose, suggesting that even in those that had a dose of a BMI greater than 35, rather than just a kilogram weight, that there might have been an advantage for the higher dose of resmetirom. Anne and or Joe, I can start with Anne. Are you looking at BMI, and or are you really using the 100 kilo as the cutoff? And I'll also, as a follow-up, like, how are you getting your patients that need that higher dose through? Because at least early in the initiation of the drug, there are a number of GI side effects. I think that most of those become quite attenuated after they've been on it. But I find that the first couple of weeks are a little bit challenging, especially on that higher amount.
Yeah, totally agree. So we are following the label right now because I feel like it would be very difficult to get insurance approval based on BMI and not that 100 kilogram, dosing point. So we haven't looked at increasing dose for BMI, but we follow the label there. I think when you start any new drug, and resmetirom is no different, the first 2 weeks are critical, and side effects typically happen with this drug in the first 4 weeks. And it's a quick onset and a quick resolution typically. So if you give your patients that information, that they may have some GI upset at first, but it typically gets better fairly rapidly. And then you give them access to a provider who can help them if they have diarrhea that needs treatment, or if they have nausea. We haven't had a lot of discontinuation related to side effects of this medication. It actually is pretty well tolerated overall. And for the minority of patients who do have really more severe side effects, we just treat their GI, side effects with typical treatments.
Yeah, I would agree with the following points. One is, this is a new drug. Like any new therapy, the prescribers have to be comfortable. And if we're going to deviate from the package insert or the recommendations, I think we have to have good reason and data for that. Thus far, I haven't felt that the data was present to use BMI as a surrogate rather than the weight. So that's number one. So my answer is no, I have not used BMI. Second, the question then is the return on that investment, or is the juice worth the squeeze? So let's say we increase the dose now that we know that the higher dose, especially for heavier patients, is better. Can you help them get through that initial 2 to 8 weeks of side effects? And is it worth pushing it early on to try to capture that marginal benefit? And I think the answer right now is no. For me, I want to make sure my patients take it. I know this is not going to be a 2 weeks and off. We're looking at months and years of time. So I'm following the package insert for now. Second, I'm noting that if they do have a heavier weight, to make sure that we use that appropriate weight. And I think this is reinforced by the abstract that Anne showed. And then third, there was another abstract at AASLD that looked at genetic variants in response. And I think clearly different from some of the other GIP1s like the tirzepatide, the resmetirom did not have differences by the PLPAs or genomics. So I think right now we're using rough ways of determining what dose, and we should just use the weight until we have further data that will guide us.
All right. I want to thank you both. I really want to thank the audience for participating. We have run out of time, although there were a couple of questions that were still left. I know that I always try to make myself as available as possible, but we'll go to the next slide, which is just a reminder that you want to do the post-test and the instructions on how to get credit for your participation in this program. So if you need credit, which you should get credit, you are required to complete the program evaluation, claim your credit hours through an online platform. You can use the QR code to get started and then do your post-test program evaluation credit selection, and you should be set. All right. Thank you, everybody. Have a
Thanks,
great
everybody.
night, and we'll find GLPs in the water, although I think they have to be injected, so that may not be as effective as our statin therapy.
Yeah. Thank you, Dr. Rowe, and thank you everyone from Focus Med and CLDF, as well as the whole team for supporting us do this. Have a good night.
Yeah. Thanks,
Good night.
everyone. Good night.